I start, I want to say one thing. I want to give a special thanks to my wife, Missy. She's back there. If she could stand up, y'all give her a round of applause. It's a special day because it's the first time she's ever seen me speak live. Of course, she gets to see that every day, so aren't you surprised she actually showed up for this? But she tricked me. I'm sitting at the airport yesterday with another buddy, JD, and we were sitting there, and one of her friends walked up and was getting ready to get in the gate, and I said, "Robin, what are you doing here?" She said, "Well, it's a girls' weekend in Dallas." I said, "It is? I thought Missy was coming to be with me." So she's been gone. She's been gone every night. So I love you, Shug. All right. So I want to start, and I'm going to ask Glenn before we kind of get going, just to give y'all a background on this just unbelievable hotel, a very special place in my family's heart. And I'm going to let Glenn give you a little bit of history real quick.
Well, the Gasparilla Inn is 110 years old, historic hotel. We've got about 160 rooms, golf course, beach club, right on the Gulf of Mexico, south of Sarasota. Same family's owned it for about 75 years now. We're happy to work for them. And there
It's
you
a
go.
little slice of heaven.
It's very nice. We like it.
Yeah, we'll get to that later. I'm going to play a video real quick, and this kind of gives you the story of what's happened down there. It's a little outdated, but it's a couple years old, but here we go.
The inn itself is, the people are kind, and the people actually care about each other, and they go out of their way to make you feel welcome as an employee, as a guest.
You know, with the benefits that the inn has brought forward to us, especially with healthcare, has been, you know, a welcome change from what was before and what I've seen in other companies as well.
The fact that everything is so hidden in healthcare across the board. I mean, the hospitals are the same way. How much does it cost? Nothing in America is sold that way other than healthcare.
Being here for 25 years at the inn, we've seen many different insurance programs come through. So when they decided to go self-insured, I didn't really know what that meant exactly and how that was going to go for us. For the last 4 years and coming to understand the insurance, absolutely. I hope we can keep it forever. It seems to work out well for both the employee and the company.
It certainly has. Yeah, I think it does align with our core values, being that we're, you know, family owned and we operate as a family.
Coming here and becoming a part of the family and receiving this type of offer meant so much to me.
We went and found and deconstructed the whole system and found the best components and brought 16 plus solutions together and seamlessly integrated them into this fair cost health plan that we've created. All of these years, the savings is probably around 1.6 million, somewhere in that range. What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting.
Your benefits coordinator, in our case it's Liz, who's great, and she's always extremely helpful.
Having someone that you can call any moment of the day and say, hey, I have this issue, help me.
I am here and available to them 24 hours a day, even on the weekends, and to guide them if they have any questions about where to go, who to see, how to handle their plan.
Being that everything's transparent, there's a clear line of communication.
We can help redirect people to good care at good pricing.
We have a partnership with a local radiological facility, and because of the rates that they have agreed to, our members pay absolutely nothing.
How much money have I saved? Maybe a little over $5,000. For me and my family, that means a down payment for a home.
We're saving probably between $5,000 and $10,000 a year as a family. No, that's the difference between a few mortgage payments or college savings for my son.
Try to get the employees to understand it's a collective thing. Something we bought, you go use it or don't use it. It's our health care. If we all approach it correctly, we all have to pay less money out.
That was a video by Patient Rights Advocate. It wasn't something that Glenn and Liz paid for, and I certainly didn't pay for it. But they had heard about some of the things that were happening in Florida, and they wanted some case studies to share with HHA Secretary at the time, Alex Azar, and then also the White House. And as a matter of fact, I believe, Glenn, y'all were, I think, Encina went through a month-long of interviews to meet President Trump right at that conference one time.
Maybe. Probably. If you want to say that, Carl, that's fine.
Okay. Well, that was mine. I guess they lied to me. But anyway, one quick story that is funny. When my wife and I and our family were down at Boca Grande, and it was Memorial Day weekend, and I'd somehow finagled a meeting with Glenn, who I didn't know at the time, and we don't make cold calls. And I said, Missy, I didn't bring any nice clothes. What do we do? And I said, I always try to be different. So I just said, I'm going to go in fishing shorts, a fishing shirt, and a visor, and reek of sunscreen, and flip-flops. And so I walked in, and Glenn said, all right, what do you have? What do you got to sell me today? Typical CFO. And supposed to laugh, Glenn. So Glenn, I looked at Glenn and I said, how are we doing so far? He said, well, no one's ever come in dressed like that. And I said, I'll take it. And then we went on. And then the next, we had another meeting 2 days later. This was May of 2014. And then we got hired on Good Friday of 2015. So anyway, I thought y'all would get a kick out of that, but that's how we ended up meeting. And so, all right. So we're going to talk about how to build a higher performing health plan. That's what this discussion is really about. And we want to make it interactive with Glenn and Liz. And Cristy is going to help. Cristy is one of our Mitigate partners, and she's going to help through this process as well. So how did we get here? I would say, Cristy, what was it, back in February? We got it was James and Dr. Smith and Jay Kempton called you.
They called us up and said, hey, we want to hear about some case studies. And I said, we'll do you one better. We have 3. And, let us give these 3 case studies and let your audience pick one. And so these guys are the winners. So if you ever want to see that 2-hour video, it's on the YouTube
Cristy
channel.
wouldn't be quiet. She kept talking the whole time. All right. What'd you say? I hear Dr. Gross laughing out there. So what's in this for you? I don't know. Y'all figure it out. Hopefully you'll get something out of it. All right, key themes today we're talking about employer-built health care versus insurer-built. We're not going to break these down because we're going to cover them as we go. We're going to talk about active management versus passive management of your health plan spending patterns. And then we're going to talk about neighborhood health care, as we call it, relocalizing care. And you're going to see some real examples of how getting money off of Wall Street back to Main Street works in this case study. And I always say it's going back to the Marcus Welby MD days. Of course, there's probably a lot of young people. If you don't know it, go Google it. But some of you I know what it is. That's what we have had happen at the hotel. And then build community-owned health care and not insurer-owned health care. Maximize your local care team using the community pharmacist, the doctor, the hospital, and the patient. Put the patient back in the center, which all of you fine folks out there already do. And then again, you can have 10 times the benefits for half the cost. And then there is a way for you to have health insurance your way and on your terms. So the path forward and the theme, and it's funny, when they asked us to speak, they were talking about it. We've always used this. If you want to stay passive, you want to go active. It's your choice. So what do y'all want to do? All right, well, we're done. All right, so here's just a couple of things that we were asked to talk about. This is not all roses. It's work. And there are challenges with it. So we're going to get some involvement from these guys here. When you pull back that Book of L, Blue Cross, United, Cigna, and Humana, this thing's a mess. It's so messy, it's crazy. You got to want it bad. It can be noisy. We often say, it's taking the road less traveled, which Glenn and Liz were really, I think somebody called it the OG, their original gangster or something. That's some saying. I didn't know what that was, but they were the guinea pig, really, to go down this road. So, Glenn, what made you decide to listen to some crazy person like me?
Well, knowing you were from Georgia, I know it was a big leap. So, but I've been buying insurance for resorts for a long time, and both the property side and the health side. Property side, every year you sit down and go, we had X dollars of claims. Here's your new premium. It kind of made sense, the mathematics of it. On the health side, you go, what were our claims last year? We're not going to tell you. You don't need to know. Or if you were bigger or smaller, you could get it. So Carl came in and goes, well, no, you should be able to get your claims. And I said, well, we're in this treadmill with United Health, Blue Cross. You get a quote from United Health. Well, Blue Cross won't quote till you tell them the United Health quote. It's like, you don't do business like that with anybody else. So he goes, we can eliminate all of that and make your own plan. And I said, well, that makes more sense to me because it's something we can manage We understand what the costs are going to be. We can control the cost. And it just made way more sense to me than having the broker of the month come in and tell me, well, we're really good friends with Blue Cross. We'll get you a better deal. And, we've heard that story a million times, but they can't get a good deal until you tell them United's quote. So it just made a lot of sense, even though he was from Georgia, to continue to do it. So we still can't get him any decent pants.
Hey, should I continue? Y'all think? The whole thing about Gasparilla, if you read on it, it says get your pinks and greens out when you go there. I think they could all attest to that. That's the kind of thing. So in the true spirit, this is a Pink Elephant tie. They have a restaurant called the Pink Elephant. And so it was actually designed for them. So anyway, I've got like 4 colors in it. And they're all bright, Glenn. They're not dark, just so you know. All right. So let's talk about this. This is probably the biggest thing. So when we're out there talking employers, everyone asks, oh my God, what if I don't have that BUCA logo on my card? I don't have Blue Cross. How does it work? So Glenn, why don't y'all speak about that? Or Liz, y'all both talk about it because it does come up.
Liz deals with that more than I do with the employees, because you get the card, it doesn't look the same. It doesn't have a Blue Cross on it. And a lot of these doctors' offices, their frontline people are not the most ambitious, I guess we could put it that way. And so we don't take it. So they're immediately on the phone to Liz, and she tells them.
Yeah, our card is a little unique and apparently very confusing for these providers. And I get a lot of pushback often. And so my role is to either call the provider and read to them the very simple phone number on the back for eligibility and remind them that they're under contract with our network Evolutions. And when I have pushback from that, thank God I have a contact at the network, and I stick my little pit bull on them, and she calls them up and reminds them they're under contract, and so they go ahead and treat the member.
It is a weapon, folks. They're so trained and used to seeing that card with a logo on it, and they just take it, but they still got to make phone calls. We're going to talk about that. Care can be denied at times. There's constant provider front office turnover that you're seeing. COVID obviously didn't help that. And then the providers don't make the changes in their on the system for the ID card. It happens all the time. So you got to make sure they make the changes. So as we like to say, don't hide behind the BUCA logo. I mean, gosh, guys, all you employers out there that have these logos, put our logo on there. We'd love it. I mean, you're giving away free real estate. It blows me away. These big employers don't even have their logo on the card. Such a game. So what it ought to have is your logo. And Gasparilla Inn's card looks just like this. This is how it works. So let's look at the back of the front of it real quick. Same type thing. And then on the back side, this is the part that I never have understood. So we have different tools and sources the employees can call. And on the back of the card where it says eligibility, the provider can call to verify if Glenn's employed here or not. They do that now already. So you just have to the employee has to walk them through and really be a CEO of their own health to do that. Then you got your pre-cert part. I know y'all guys love pre-cert out there, and we'll talk about that in a minute, and in the pharmacy. So we also put this together so that employees can take this. My doctor won't take my plan. How does that work? Why is that? It's a nice piece that they can use. I need to make sure I get that one back to you guys. And then another one that was done was this one. From an educate standpoint, Liz does such a great job. Communicate. And it's continuous. So this was a piece we did this year, know before you go. Liz and I drew this thing up so you can give it to the employees and know before they go to a physician, to a pharmacy, to whatever. So it just simplifies the message a lot and makes it easier because this is different. It's definitely different. And then I think this is another problem. When you got that BUCA logo on your card, you're not a CEO of your health. You're letting the insurance company do it. People got to take control. And it is a little more cumbersome at times, as they said. But is it worth it? Is it worth it for better care and what we're talking about financially? We'll show you that as we go. All right, so we'll jump in. Liz, y'all have about 130 year-rounders or so. You swell up to about 215. Y'all are open. They're open October 5th, and they close usually right after July 4th. And so they go from about 215 back down to 130 year-rounders. So that was one of the challenges when we got involved. There are 450 total employees, but about 270 benefit eligible. Did I get that right?
Mm-hmm.
All right. All right. This case study's been featured all over the place. Health Rosetta featured this case study. If any of y'all want it, let us know. To my knowledge, and I can only speak to what I remember, it's the highest grade that a plan has ever gotten from the Health Rosetta. I don't know why it was a 93. It ought to be 100. I mean, when we go through this thing is, it's the best benefit plan in America. Liz and Glenn deserve a ton of credit for what this is. It's pretty phenomenal. I mean, if this doesn't work out for me or the world changes in healthcare, I'm going to work there if they'll let me.
Yeah.
Me too.
Figured. What a nice fellow. All right. It's also been featured in a couple of Dave Chase's books. It's a case study, the most recent one, Relocalizing Care. It's in that one as well. So again, it's been all over the place. And most recently, Payer Compass, one of our partners that y'all know that was here, Kelly Jackson, Greg Everett, and their whole team, they did a whole video about it and this, what happened, and it's been featured in many webinars all around the country. And then lastly, Marshall Allen, he was at our conference, and he, in his book, Never Pay the First Bills, came out June 22nd. He dedicated a bunch. That was our favorite quote. Our health system in broken. It was made this way on purpose. And then there's the Gasparilla Inns mentioned in here as well. So if you hadn't read the book, you should get it. And again, just to give y'all a flavor of how many places they've been. We did an event down at Gasparilla, and it was just absolutely beautiful. It's just what a great place to be. You look out the right, and there's the Gulf of Mexico out the window. But we did an event down there, and Liz and Glenn were on a panel, and we spoke. And the theme was how to crawl, walk, run, and fly. Controlling costs is not a spectator sport. By the time I got to their session, we talked about it being this journey. When it got to their session was what flying looks like, because these guys are flying. They're out there. They threw themselves in the deep end in cinder blocks back in 2016. No hesitation, other than to yell at me every now and then. And then this is a picture of the event. You see the beautiful Shell fireplace behind the scenes. That was Glenn, and also DeSoto Memorial Hospital. You hear more from that from Dr. Grossamar, Greg Everett, and everyone. So that was kind of our event that we had. All right, so let's go through their kind of perspective and the challenges we faced. They were averaging 12% increases, Glenn. That's just your point. When we pulled it up, when I asked Glenn, what's your loss ratio? He goes, I don't know. I said, well, it's a law. So, and I'll just say this. When I called the insurance company, are we allowed to say who it is, or you want me to keep it? Okay. We called United UHC or some company, United Healthcare. Anyway, it's on the screen already. But we called when Glenn hired me that he couldn't get a loss ratio. So when I made the phone call, this fellow named Steven answered the call. And I said, hey, Steven, I have one question for you. In healthcare, you're either a performer or a non-performer, and I've never met a performer that worked at an insurance company. Great way to start a relationship. It worked, and we became buddies. But I laughed, and I can pull that off because I'm a Southerner. But we laughed, and that wasn't supposed to be funny. But we laughed, and I said to him, hey, I need this information. Here's the state statute that proves we can get it. He said in his 15-year career there, the rule was never, ever for me. He said to people with doors, that had offices, to give that information out, ever. I'm not making this up, ever, unless somebody brings the state statute. You know how many times somebody brought the state statute to him? Yes. So that's what you're up against. We'd like to call it cartel if y'all have never heard that from us. So anyway. Marshall Allen also wrote an article about insurance companies hand out cash to brokers. Glenn was featured in there. All of us were. And it tells their whole story about the hotel not being able to get their data. 65% loss ratio, folks. The carriers want 75%. They were printing money. And what happened to Glenn is we were talking about it. He says, man, their stock price is just going through the roof. And we're taking them on the chin. So we decided to make a change. I moved past that. So anyway. And Buca's extracted millions from the community. So let's just quickly, I'm going to fly through these for sake of time. Look out the conference room window and look at all the names on the stadiums and the buildings. And there's Glenn and Liz sitting over here by themselves. That's a real picture. That usually generates laughs. So I'll have fun with this one. I've shown this one a lot. Look at the top 20 of the Fortune 500. Every one of these companies are middle people. They don't make a dead gum thing. And I can't spend the time. I'd have a field day on this one. It's just so infuriating. If you had never seen that, guys, wake up. And from talking around the country, a lot of people don't know this stuff. It's amazing. And right before our very eyes, this has happened. All right. And then this is all those companies and the way pharmacy is distributed from an employee to a member. I want you to see this. All those people are in the top 20. And I'm not real smart, but that sure is a complicated way to get a drug to a member, isn't it? Sure, there's no money changing hands anywhere in there. But that's not how it works. And then this was funny. I think I got this from PUT, Pharmacists United for Truth and Transparency. It's a monopoly board, and that's what you're dealing with. All right, so very diverse population with seasonal employees. We just talked about this. And when we started working, I went to Glenn, and it was 15. We had an opportunity to really make a big change, but we were able to convince United to basically hold the rates. And that was when the Affordable Care Act said you're going to have to offer coverage to everybody when they've accumulated enough hours. So we thought we'd let them be the guinea pig the first year. And once we saw again how the seasonals reacted in the plan, we still ended up with a 65% loss ratio. That's when we made the change. And the Southwest Gulf Coast is the most expensive healthcare in the country. No matter what you Texans think, I'm telling you it is, and I'll prove it. Look at the bill charges to Medicare right here. Most expensive in the country. When you look at the knee replacement surgery, billed averages in green. The cost that it cost them is in orange. So that's what we're dealing with, and that's what Glenn and them were faced with all the time. And then we look at a CT scan in Tampa. That's what it costs the hospital, but you see what they bill out at. So I know y'all already know all this stuff, but it's crazy. So we had to deal with that, and that was their premium that was projected July 1st of 16. So the solutions basically eliminate the middles, and we moved into this self-funded fair cost program with independent TPA. It was built around these deficiencies in the healthcare we identified. Embedded conflicts of interest, i.e. cartel. Lack of quality and pricing transparency. Fraud, waste, and abuse, medical billing errors. Traditional PPO discount game. Pharmaceutical shell game. And lack of information data. These are the struggles that a health plan has, and what we try to do is overcome them in what we built together. And we call them opportunities. It's the 6 opportunities in healthcare where you can change your plan around. Healthcare Simplified, I got this from Dr. Gross. Kind of hard. My dad was a 40-year OBGYN, and he told me this years ago. Kind of hard to take care of somebody when you're looking through somebody else's ear to get to them. So you got to eliminate the middles. People go, how do y'all do this stuff? It's real simple. Eliminate the middles. So active management, eliminating passive management. You're going to hear that over and over. We're going to talk about some different examples. So here's a traditional passive plan. It's a bundled program. You could be self-insured with a BUCA, and we call it BUCA Insure Built, but they have it all put together for you. And they don't have the best cost containment because it goes against the inverse opposite of their stock price. So it's misaligned incentives. So what we try to do, and really we love Buckminster Fuller, this quote, we created something that made the existing model obsolete called the Fair Cost Health Plan. So here's how it works. And we talk about a health plan like a house. Start with DPC, and there's only, 100 of y'all in here? Big fan. I mean, Dr. Gross has done some amazing things with our other client, DeSoto Hospital. And then Glenn and Liz use basically a clinic on the island that kind of acts like DPC, we feel, and the prices and everything we have is very similar. Then you rebuild it brick by brick, and all these bricks are cost containment components in a health plan. Okay? I'll let it roll out. I know it looks complicated, but I promise you it's not that bad. And you end up with an employer-built, actively managed plan. These bricks are supposed to exist in these health plans with the BUCAs, but you tell me if they do. Now, as we like to say, from Liz's standpoint, the cost is pretty complicated. How are we going to explain this to the members? All the members need to know is one call, that's all. Where's the front door? They don't even know what's behind the sheetrock. They don't even know what the electrical and the plumbing. All those components work, and we'll get into that later. But as I like to say, that no house is complete without a dog. So go Dogs. Had to do that for Glenn, but because Glenn went to LSU, then we'll put Mike the Tiger out there, make him feel good.
Team that actually wins.
Yeah, we'll see. We'll see.
Here we go.
We'll see. We don't have time to go there today. And relocalized care, neighbors talking to neighbors. That's what this is about. And you have to get the middles out to do that. So let's look at what that looks like. This is kind of our definition. Eliminating the counterproductive barriers that are there where that members can be taken care of. And I think we've done a good job of that with most of our clients. But I mean, again, the Gasparilla Inn is just a phenomenal example of how that can be. And that's what we have to do, folks, to take this back. You know, patient rights advocate, I meant to mention did the videos. Cynthia Fisher and Ilaria Santangelo and Linda Bent and their team are great. And they're boiling the ocean. They're up in D.C. But we got to get it at grassroots. We got to boil the rivers, the creeks, the lakes, and we'll meet in the ocean. But if we don't change this on the ground here in the grassroots effort, they can do all that they want. Y'all know about the transparency and $300 a day fine. I mean, they just sell one aspirin a month and they'll cover that. So we got to fix that. So this is what we think works. Also, for you docs out there, how many of y'all spend millions of dollars a year on prior arts and pre-search? Raise your hand. It's all DP, so we got a few. We have been able to build plans where we don't have to pre-search prior to everything. You'd like that, wouldn't you? Be pretty good for you. So it is possible. And a lot of these other programs don't work like that. So that that's customization, employer-built plan. And we use the cost and quality transparency tool with direct cash pay. We'll play a video real quick. What if you bought grocery, you buy health care?
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both. Just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
Now, y'all laugh, and normally when we do these talks, I'd be chiding you right now. There's nothing. What's funny about that? Why the heck are y'all doing that in your plans? Why? It's not funny. And like Glenn says, where else in America would you ever buy anything like this? Would you buy a TV set and find out the price 30 days later? Of course not. So anyway, that's a good educational video. So lack of price and transparency, carrier complicity, as we like to call it. The Bucas know all about this stuff. I think it's pretty obvious, yet they stand by and passively pay $40,000 or $135,000, and they're doing it with your money. And that's what Liz and Glenn were saying. So basically, the networks and all the way the cartel works is they've obscured the price. No one knows what it is. It's all based on discounts off a fictitious starting price. And again, with a third-party payer system, once Christie's hit her out-of-pocket max, she don't care. She can go wherever she wants. It don't cost her, but it costs Glenn and Liz a lot of money. So anyway, that's the bottom line. And so here's what we did to fix it. You got to get the employees to care, and I think Liz has done a remarkable job of doing that and illustrating what is possible. So just quick, I'm going to go quick for the sake of time. This is North Florida, and I think y'all seen this, knee replacement. Where do you go? What hospitals do your people go to for care? Look at the number of procedures done at each hospital. Look at the price. I'm going to go fast. He wants to go to Health City Canaan help for that. Or Dr. Gross did $17,000 at the Soto Memorial. Dr. Gross set up a knee replacement down there. Had a surgeon come in from Sarasota to do a knee replacement. That's relocalizing care in a community that needs it. So that's what's possible. Look at the difference in the amount of procedures and the prices. So y'all know, I think all of y'all already know this. Price and price not. Now this is, I think this is from Leo Wisniewski, if I can pronounce his name correctly. But look at what knee replacement in Jacksonville is if you have Humana, or if you have Aetna, Cigna, Blue Cross. Sorry, did y'all see that? The reason I'm showing it is you can't buy every one of those companies to get the best price. You have to buy one of them. If you're not as smart as these folks are, you don't have to do it that way. But that's what you're faced with out there. So we solved the lack of price and transparency. We have access to CMS databases. what Medicare pays, the DRG codes, what hospitals bill at, and it's a nurse advocate that runs that process. And Liz, she does is directs a lot of people through this program that we have with there, and they identify the quality, cost effective. But you got to design the plan correctly, and I say this all the time. Plan design's got to reward good decisions. So doing this stuff and not fixing your plan design will never work. So Dr. Keith Smith and patient rights, again, we'll throw some love out to you guys. Y'all are as transparent as it comes. That's what you guys are about. So you got a PPO. How do you get the employee to pick physician B over physician I? Glenn plays golf with physician I, and he's a good fella, but he's Dr. Hodad, hands of death and destruction. How are we going to get him to physician B? How's he going to know? And my dad was a 40-year doctor. I'm not going to do the story, but I can tell you all those stories about C-sections and so forth. There's 60 doctors that do knee replacement in St. Pete. 14 of them did at least 50 a year. 8 of them, we looked at the outcomes and the readmit rates. Got all the way down after the cost of implants. 4 fell out of the funnel. What are the chances of an employee picking 4 out of 60? That's what you're faced with. And so that's what this program did. This particular doctor also had 4.47 deaths doing knee replacement. Now, as my dad so eloquently pointed out as a physician, son, he might have dealt with 80-year-old people with a lot of comorbidities. Good point, Dad. But it ruins the message. I mean, all right. And then if you look at the hospitals, how many procedures do they do? Look at the one that did the most, charge the least. And they're more proficient at it. So when Liz is dealing with an employee, where do you want to go? People do it all the time, or people do it twice a year?
Hey, Carl.
Yes.
You know, and I really respect Dr. Rice, who was just up here in the breakout session and pointed out, and it is a prevailing opinion of the, of the time, that we should decouple health insurance from the employer market. But what you say, what is the chance of an employee coming up with the right solution? Well, what's the chance of an individual coming up with the right solution too when they don't have an employer like this one, helping and guiding and navigating and advocating for and all that? I think that's pretty slim too.
Good point. So there is a negotiation opportunity here, and we call it active management opportunity. The data is available. We got to get it in the hands of employee and consumer. Support's there, and we use cash pricing whenever possible. So also, you're going to hear it 20 more times. Plan design's got to incentivize better decisions. And the way Glenn and Liz built this plan is the members will vote with their wallet, like this wallet.
Sad.
He still owes me from a bet we had.
Oh, that is.
It took me a year and a half to pay him, so it's I'm guilty. All right, so we were able to. You're challenged down in that region of Florida, and so what Liz and Glenn, they wanted to give their employees access to go wherever they wanted to go, and we knew that we could, if we put in a cash program, this could work through our cost and quality company. So they have a number of members that have had babies at a hospital around the Sarasota area. That's all I'll say. And we were able to go in there and get the cash price at $6,500 then, at $7,500 now. The anesthesia went up. But that hospital charges $37,000 for a vaginal birth. So with your Buca discounts, $18,000, $19,000, not good. My dad about fell out of his chair when I told him they were charging $37,000 for delivering baby. So that's been a good tool. Now, again, you got to get the employee involved. And what we've done is, what Glenn and them have done, and Liz, is if the employee decides not to follow the advice of the nurse advocate, then their plan is going to work like it always has. If they follow it, then maybe they have just an admission copay. These guys have no deductibles. You're going to see in a minute. They don't have deductibles in their plans. But that's how you have to do it. So anyway, Liz, you want to speak to any of this cost and quality service? You want to speak about it? Not yet? Okay. All right. So again, solution. The Inn hired a benefits champion. They implemented this program, and they hired Liz. So we're going to let Liz talk about that. Liz is kind of the mother hen of the group. So we'll let her speak a little bit about her role, because I will tell you this role is critical to having a good health plan. With the amount of money that's saved, you can afford to have someone as qualified as Liz to help do this. And she's not HR, she's not payroll, she's strictly benefits champion. Liz, why don't you speak to it?
Okay, so when the Inn decided to go self-insured in 2016, they brought me on as a dedicated advocate for the members. And my job is to educate them and to assist them in getting their treatment or the best treatment for their situation. I help them with claims resolution. I've even so much as taken a girl to the hospital and stayed with her through an emergency. She had a surgery. And the reason they put me in is because HR, unfortunately, was not going to be able to tackle the volume of what's involved in administering to a self-insured plan. We have many, many partners, and the partners have offered us steep discounts, and they've offered us exceptional care, and they've accepted us as their partner as well. And today, it took a little while, obviously, but today I can actually speak with the providers. They know that I'm advocating for them as well. Everybody's on the same team. We want to get everybody well. You know, it's a lot of hand-holding, a lot of mother hen, as Carl likes to say. But the only way that it's going to work is to actually get to know these members. You have to get to know them so you can get them on the right plan. I had once when I was first starting, I had a gentleman wanted to, I'll start again. We have 3 levels of plan. We have a gold, silver, and mech. The mech is our minimum, silver's in the middle, and gold's the best. Well, the silver plan excludes certain items. And this gentleman had a daughter with spinal bifida, and he wanted to save the money, which was only $40 at the time, and stay on the silver plan. But thank God I got to know him, because if I didn't get to know him and advise him to take the gold plan, then he would not have had coverage for his daughter's spinal bifida outpatient procedures, and he would have gone bankrupt. So, you know, and that's kind of what I do every day, is get to know them, help them the best I can, and point them in the direction. In fact, I had someone call me the other day while I was on vacation and said, I need to go get an MRI, and I forgot what to do. And they wanted to go to the emergency room, which is going to cost her thousands and thousands of dollars to the plan and $300 for her just walking in the door. And I had to remind her, well, we have RAVE, and our radiological facility has discounted us so significantly that you can go there for free. And their hours are all the way up till 10 o'clock at night, so she didn't even have to worry about that. And that's kind of what a typical day looks like for me. You know, It's a lot of get to know you, hand holding. I chase people down sometimes, and I see a prescription come in, and I know darn well I can get that through our international program for free. It cuts the cost for us in half, and the member doesn't have to pay anything. And it took a while to earn their trust, but I think that they do now, and they know where to come, and they know who to ask, and it's really working for the plan.
You know, so many people come up to me and ask me, how do I get past HR? Because HR is the one barrier. HR is the folks that nod their heads at me and they say, yeah, it all sounds good, but that we can't handle all that. Or maybe they won't even admit it that they can't handle it. They just decide to put up the roadblocks. So just imagine if every one of you had an HR director sitting at your tables, all of them would have heard just that right now there and said, how do I get that? Because that is the key to me standing in the opposite of opposition, me standing in favor of something like this.
Yeah, I remember when, one thing I will tell you, don't you get between that member and Liz, because it don't end well. I've got scars to prove it. She's the best, and she don't take no for an answer, that's for sure. When Glenn, it just truly, honestly, when Glenn and I were talking when we did this before we knew Liz, he was thinking, hey, we need to do this position and have it under the finance, CFO. And I'm like, so I talked to my co-founder Mitigate Partners, Barry Murphy, and I were talking, and we told the story when we were in Gasparilla, and I'm like, this guy is going to not put it under HR and going to put it under finances. It was just foreign to us of what we had seen. And I'm sitting here, I'm total agreement with what he did now, but Glenn was a genius. So I'm going to say that one time so it's on record. Glenn was a genius, even though he doesn't pulls for the wrong football team. But anyway.
This is recorded. I'm going to play that back for Glenn every time he gets grumpy.
Great. So when he calls me, I got to say he's a genius. But he had the foresight, and that was brilliant, and it's worked really well. And Liz, I mean, tirelessly, when we use some international importation, and she tirelessly gets the list and looks through the claims and finds people that could get a medication for free. She also looks at the claims, all the funding requests that come in weekly. And I mean, again, studies with a fine-tooth comb. I will tell you, every employer in America is paying these claims. And I love TPAs, but I mean, it's hard. And the comment we've always said is all TPAs suck. It's fine, at least suck you the suckiest. No offense to Kempton or anybody out here. Nobody's laughing at that. But That's the hardest part. So employers are blindly paying claims. Not with Liz. She catches them. We thankfully don't have that many mistakes that she's found, but that's so important to have that person watching it because it happens. Everyone's going to mess up. All right.
And Carl, we won't say what Liz's salary is, but whatever it is too small. But the
You better be
money,
careful.
the found,
You're fired.
the found money between going from the old way to the new way, that there's found money in that, right?
Sure.
When you put on your winter coat and you reach in the pocket and you pull out a $100 bill you forgot about, the found money in making this change is where you found the money to hire her. So stay in those BUCA plans of why HR directors don't have somebody like her to pick up where they have to leave off.
Yeah, and honestly, I have to give a lot of credit to George Costanza. So what can he teach us about healthcare? Y'all ever seen the episode when everything in his life had turned out bad and he said, maybe if I do the opposite, things will work out for me? So he said, I'm unemployed, live at home with my parents, and she says, hi, I'm Victoria, have a seat. So we like to say that, make better life decisions, do the opposite. What Gasparilla is, they did the opposite. They don't charge for most things that health plans require you to pay for. We're going to get into that right now. They don't charge for it. They did the opposite. It's just like diabetic test strips. Why in the heck are we charging people to get their diabetic test strips when most people don't have $500 in their checking account? They're not going to get the test strips. They're going to end up in the ER, and they're going to become an inpatient admit and cost your health plan millions of dollars. It's crazy. But the insurance companies and the cartel have taught us not to do it that way. So what I would tell you, whatever someone tells you, and if you talk to an insurance broker, do the opposite of what they tell you, unless you're talking to Christy and I. All right. So solutions, we implemented a proprietary claim analytics program, which we could do a better job with. I'm sure Glenn's going to give me a ration here in a minute. But you can predict what's going on within a group. And our claims analyst has over 32,000 members. And this is pretty basic stuff, guys, but the top 10% drives 73% of your costs. That happens pretty much with every health plan. And you got to identify those people and treat them. Luckily, Gasparilla, y'all have a fairly older population, but we don't have people with too many comorbidities when you look at your group compared to others. So anyway, the bottom part of your group doesn't cost you much money, but you got to identify them. Dr. Gross has done on the hospital, and he'll talk about tomorrow, has done a great job in this area with a sicker population. These are some of the opportunities you have to intervene, switching drugs, catching unavoidable visits, etc. And that's one of the things you can do. You can also do this, drill down this deep with the diabetic piece. This is not Gasparilla. It was a much larger company, but they were below the benchmark there, above it here in prevalence. And of that, only 121 people did not have their HbA1c test done. And there were 401 that didn't have it less than 7. Pretty scary. That's the kind of drill down you can get. All right. And we implemented integrated coordinated care, IC squared. Let's talk about that for a second and go through a real life scenario. Liz, I don't know if you want to do it or you want me to do it and talk about it, but how this works, and you want to do it? I'm handling it? Okay, I'm going to handle this? Okay. So what we have is we have a HIPAA compliant board where the member is taken care of. And when you have 20 plus bricks in your health plan, each of those bricks has access to this platform. And much like social media or whatever, I don't do Facebook, but LinkedIn, you tag them and everyone is aware of what's going on with the member. What was happening is there were 400 emails flying around with everybody communicating. It's just so hard to manage. Here, you're only notified when someone does a post. So we've had many circumstances. I think it was one of them with the physical therapy and then in-home care and all the different things where the care is coordinated. We had one, it wasn't them, but we did have one that during COVID, this particular patient had to go into a long-term acute care center, and we were able to try to get them with Kindred. We have a direct contract with Kindred Healthcare, the biggest LTAC company in the country. And we tried to do that, but that was in St. Pete, and that was too far of a drive for this member. The member wanted to see his wife. It was important he see his wife. So we were able to get him into a ground floor room at an LTAC that they were able to go to get care so his wife could look at him every day and uplift him and make him feel better and get him out of there. That's the kind of care, the team that takes care of these members loves these members. That's not happening in the Buka world. So we're talking about integrating it all together so that everyone's on the same page. It's frustrating sometimes for Liz. Sometimes things aren't answered as quick, but for the most part, we just had a good success recently with all that. So it's a great way to communicate and not clog your email up. And we hope to have Dr. Gross on that platform too with our other client. So plan change is effective. They've saved, and Glenn and I will argue about this, $4.5 million since 16, and I'm going to explain that to you. We thought they saved $2.3 million over 5 years, so I think it's been a lot better. And they've significantly improved the benefits. Eliminated deductibles and coinsurance. You can't do that because everybody will go crazy with the health plan. Who wants to go sit in an MRI and hear the bank, 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 bank to avoid work? Come on. I mean, that's what everyone was taught. It's crazy. So copays only, and they moved from 2 plans to 3. Liz said gold, silver, and a MAC. Reduced deductibles to 0. Out-of-pocket max is $4,500, $8,500 for a family. Liz told me when we were down there in June, they only had 2 people in 5 years hit the out-of-pocket max. 2. That doesn't happen. And I don't even know how they did. They must have had to go to the hospital 20 times because it's about impossible to hit it with their plan. You can go anywhere in the country with their plan. You can go to Mayo, Cleveland, wherever you want.
And you know why they can go anywhere in the country?
Tell them.
Because they pulled that Buka logo off the card. Yeah.
And they have a clinic down the street, like we said, that operates like DPC. Beautiful facility. They can get in a golf cart and ride down the road. So they've utilized that, and that's been a really good partner, and that's been a good success. And they also direct contracted with 4 hospitals within a 50-mile radius, and even got the CEO of the hospital to speak at their benefit education meetings. Who's ever heard of a CEO of a hospital coming to benefit education meeting? So pretty amazing what these guys have been able to do. We negotiated with a community pharmacy. We talked about this. They're on an island, guys. The island's about 7 miles long. It costs $6 to get on the island. So I reached out to community pharmacists that was already doing business with them, and they deliver twice daily to the hotel. So you just show up in the front office or the front desk, put it in a HIPAA bag, and you can get your medications. And I think they're getting about 60% of the meds. People still going to Publix. We have a preferred, non-preferred network, but pretty nice. That's the partnership that can be created for the members. And that's putting the money back on Main Street from Wall Street. And that's what this is all about.
Hey, Carl.
Yes.
One of the things I found out by doing the same thing, striking a direct contract with an independent pharmacy for a client, and I didn't know this up front, but the actual volume of drugs that they buy for their independent pharmacies is way higher than you think it is, because all the Bukas and all the big pharma players want you to believe that Express Scripts and CVS Caremark and Optum and all the big dogs, they have all the buying power, but it's actually not true, because the independent pharmacies, a lot of them will service the long-term care community in their little catchment area, right? So they'll supply nursing home ABC with a little inventory of dispensary, in-house dispensary. So they're buying way more drugs than they dispense in their brick and mortar pharmacy to help supply the local community's long-term care facilities. So I had a real epiphany right there. I learned that a local independent pharmacy in Asheville, close to one of my clients, bought $100 million worth of drugs every year. That floored me. And so I learned right there that they're actually buying more drugs for that little community than the other big box retailers. And so when I struck that direct contract, it turned out we beat Optum, the prior PBM, for my client by 21%. And it wasn't a fluke either, because we keep repeating that year over year. So if you are DPC doctor out there and you're kind of wondering how we strike the right balance with the pharmacy piece, make friends with a local independent in your town.
Good point. We trifurcated a narrow network with 3 different choices with 3 different copays. So depending on which tier the member decides to go in, and Liz, you might want to speak to that. You want to speak to it for a second about how it works?
We have the gold, silver, and MEC. Now, the MEC, of course, everybody knows covers the minimum essential coverage. And that is very affordable to us, and we generally never have more than 20 members on it. But we don't charge the members anything for that. It's absolutely free for them. However, if they want coverage for injury or illness, they have to do the silver and the gold. And each one of those on the PPO has an in and out of network benefit and copay attached to it. I do believe, by the way, there was 2 items only with co-insurance. I didn't want you to be a liar. And that would be the ambulance and the home health care. And durable medical equipment. So after the first year that I was there, Glenn and I went through that plan document, and we went line item by line item, and we tweaked it to be very, very member friendly, and include items that wasn't in the original contract, which I think was, and I wasn't there when they were writing the original plan document. I actually got there on the first day of open enrollment of the new plan, trial by error or fire. And anyway, I think it might have been based on the fully insured plan, but we went and we fixed it. Glenn and I went through it line item by line item, and we made it very, very member friendly. On many different levels.
You've tweaked it constantly throughout. We're going to cover a lot of those.
I think this is the first year that we didn't make any changes, but every single bit of it is based on being for the benefit of the member, and seems to be working because we have quality employees that stay on board with us for 20, 30 years, and we have seasonal employees that go back and forth to their home country for decades, and I believe it's because we offer such a rich plan. And give them so many choices. And then, even if they have to go out of network and they spend more on a copay, we put that direct cash pay into it and negotiate their copay down as well. And they do appreciate that.
They were the only employer on the island when we went for our Mitigate Partners Summit back in June that wasn't having a hiring shortage.
Well, we were having some, but we just covered it well.
I didn't notice it.
They did a good job. But yeah, member has, every decision the member makes is based on their wallet, and they've got 3 choices really for care across the board, whichever tier they fall into. So she's mentioned it before. MRIs, advanced imaging, no copay. I know that, and as we found out, they've even used green imaging for some of their things that our cost and quality companies directed people when they were having to get a test done that the local radiology firm couldn't do. Green imaging, y'all know, they're back there. Dr. Dickerson and her team did some work we found out last night. And $20 copay was reduced to $15. Specialist was reduced to $8.80. And to $25 to $35, that was substantial because when Glenn and I got involved, it was an $80 specialist visit. I mean, these didn't exist, guys. These are like down the clock by 30 years. This is the thing that Liz and them did do that I think Glenn, and when one of the tweaks that was made, we call it the ologist. If you go into the hospital, you get hit with the ologist later. Anesthesiologist, radiologist, pathologist, all these things come in, and y'all know about the whole surprise billing and all the legislations out there. Once the person goes in with an office copay, it's done. They don't pay for any of that. They cut that out. So when you see the savings numbers, the member really doesn't have hardly any out of pocket for anything. Yeah, the plan's paying, yes, but at the way we've been able to build it, they're not paying a lot because of the providers and things that agreed to it. They also, colonoscopies. You go get a colonoscopy and they find a polyp, it becomes a diagnostic colonoscopy and you owe $1,500, or maybe we had one bill at the end, $20,000 for a colonoscopy. We didn't pay that, but that's what the bill was. If you find a polyp in their plan, there's no cost. So that's pretty different. And I don't know if anybody's ever had that happen, but that's pretty much how it works out there. So they've waived that. They also have this direct cash pay plan we talked about, and those can be down as much as 70% of Medicare when they're done with cash. Not only do they do all of that, but if the member does have to go to one of these other hospitals we don't have a direct contract with, Glenn and Liz are giving the members back 50% of the savings from the agreed upon price up to $1,000 for outpatient and $1,500 for inpatient to offset their admission copay. Y'all give them a round of applause. I mean, who's doing this stuff? Let's see, what else? They have preferred and non-preferred pharmacies. So y'all know about in and out of network on a health plan. That's what we did with the pharmacies. So the community pharmacy, Publix, I don't have Kroger, Publix,
Winn-Dixie.
Costco, Walmart, and so forth. If they go there, their copay's $15 less. But they're still allowed to go to the cartel pharmacy, CVS, Rite Aid, Walgreens, all day long, but they're going to pay $15 more. Where do you think they choose to go? Plan design's got to reward good decisions. You walk away with anything, remember that. And here's their copays. I mean, how about that? It's pretty expensive, isn't it, Tim? I don't know if you can afford that. So that's how they built it. They added telemedicine with a $0 copay. Some of these telemedicines that are out there, charge an office visit for. They did it for $0. They've done education meetings every year for their employees, at least 4+ a year since we started. They're sitting down there, and I know they roll their eyes whenever I show up. I know, and then Liz and Glenn keep cutting the slides back and back and back. So, but anyway, here's some of the pictures of what it looks like. We do it in a real pretty room there. That's the hospital CEO on the left, bottom left corner that was there. So, and they've used a helpline and advocacy service for the quality and cost that we've talked about. And they still contribute 75% with dental and vision included. That's quite remarkable. So the results, this is their plan versus other health plans. I'm going to go kind of fast, but if you'll look at it, there's an awful lot of zeros on the left, isn't it? Pathologies, thousands of dollars. They have admission copays when you go to the hospital. That's it. And if you choose the right hospital, it's that. If you go to another one, they still not made it too penal where the member can still afford to go, but it's going to cost the member when they choose a different hospital. And again, we all focus on the quality. If the person has to have a procedure done where the quality metrics don't line up, I'm not going to force them to go there. That's their out-of-pocket. Again, 2 people have hit it. And that's the premiums they charge for an employee only, including dental and vision, versus $300 to $500. And then the benchmarks, and guys, this is the most important thing. The national average for medical expense per employee per year is $12,125. They're at $38.17. The drug expense per member per month, national average is $125 a member because all these specialty drugs and all this explosion of them, they're at $31. This is unheard of. So they've done a great job. So they built employer-built healthcare. If they had stayed fully insured, guys, this is a tough one because they didn't. If they had, that's how much their savings would have been based on what increases they would have gotten from United. Okay, you may say it's speculative, but it's really not. You can, because we studied, and they had some tough years. You're going to see that in a minute. That's their savings since 2016. And I'm going to go into a little detail on that to show it, but that's quite substantial for a 185-person company. And all while every year trying to do better and better for their members. I mean, it's unbelievable. Liz and Glenn will tell you, when they call, we're thinking about this. Well, I always have the employer hat on. I don't know about that. We don't want them to have to deal with it. And they make these decisions all the time. I mean, it's so unusual. They really care about their employees. I mean, I think you can tell when you're there. I mean, just how happy they all are. So, Glenn, this is our favorite one, isn't it? Fractured radius, one of your best friends. $198,000 for a fractured radius. They didn't put a pin in or anything. $198,000 was what they were charged. The one below it is a fractured humerus, and there was a rod put in there for that. At the Buca discount, that's what it would have been. At their program, that's what they paid. So you want to talk about discounts, how about 89%? That's what's possible. And this is just medical claims only. So I want to take y'all on a walk down memory lane. Glenn and Liz, you remember that 2018 is interesting, but it was 2019 when we had those 3 strokes, and I was scared to come down there and drink the water. But y'all made me come anyway. Look at that. Almost $19 million of billed charges for a group of 185 people. That's what it would have been with a Buca, with a 50% discount. That's what they paid. That's their savings. So give them a round of applause. And that's only medical. We're not going to pharmacy, but that we just wanted to show that. So, I mean, I think that's what can happen when you build an employer-built plan. You can do these kind of things. All right. Also, this is all, we love this one. So per 100 employees, they're saving about $636,000 average per member per year. I know Dr. Gross, I won't say anything. I'll leave you out. But that's unbelievable at those savings they've achieved there. And then again, the medical expense per employee per year is average about $38.17. And that's the benchmark that matters, guys. All right, the renewals, 4 out of 6 years with no rate increases. I think it might be 5, Glenn, but I know Glenn, again, Glenn's a genius. That's twice in one sitting. He's a genius. He didn't have to raise the rates on the employees, but he was worried that they were getting complacent. So he raised it just a little bit to get their attention, but he didn't have to. So that was smart. So we've only been forced twice to do that. Second year had a rate decrease, which is unheard of. And the benefits, as we said, have continuously been improved. Again, there's your benchmarks again that we just talked about. And again, combined drug and medical, that's about where they are. So it's quite substantial. And again, they weaponize their plan design, as we like to say, and they're offering designs benefits for half the cost. I'm going to let you hear Dencina's story about what it means to be on this health plan.
At the age of 5, my son, he dislocated his elbow. Out of pocket, $17,000. And when I saw that bill, with having medical insurance, I felt taken advantage of. How much money have I saved? Maybe a little over $5,000. For me and my family, that means a down payment for a home, not having to rent. Coming from that past insurance to this one, I probably would have saved $17,000 that I didn't have in the first place. Yeah.
That one always makes me tear up a little.
Yeah, she's a rock star. She's great. Where's Dr. Smith? Is he still in here? He's probably. Look at what he charges for that same surgery, $37.40. So that again is what's possible with free market. All right, and this is Miss Gupton's saying, as she's known for, all it takes is good advice and a little courage. And guys, we like to think we're smart. I know Glenn and will argue with that, but we like to think we're smart. But the truth is these guys are the heroes. They're the courageous employer that did it. I don't know what Glenn was thinking, taking a chance to somebody in fishing shorts and flip-flops. But anyway, they're the ones that deserve the credit. But before we make the employers out to be too much of heroes, we need to think about this. This is going on all around the country now, guys. And so Mount Everest has a litter problem. It was once unclimbable. There's oxygen bottles all over the place because so many people have made this up to the summit. It's happening all over America. There's no more excuses. It can be done, and you can fix this. So in summary, you have to take active management of your spending patterns, which is what Gasparilla Inn has done, and just a marvelous job. You need to look for population health managers, not people that sell insurance. It has nothing to do with insurance. It has to do with taking care of people. And then using the data, you can channel things and target certain things and address certain conditions. Uber your health plan before it gets Kodak'd. And so the path forward, your choice. Thank y'all. Who wants to stay passive? All right, what a fun audience. All right. Wow. There they are. Y'all give a round of applause for Glenn and Liz. We're not done yet. We're not done. But I will open it. We want to open up for your Q&A.
I prepared all these questions, and I didn't get to ask many of them, but the last one, the wrap of them all. So, Glenn, Liz, would you ever go back to the old way?
No.
Why would you?
We have too much. We like the control aspect of it. We have a lot of partners, obviously, and we got to change them out as we need to, but it's just the control of building your plan, managing your plan. It's just, it's not an HR deal, it's a financial deal. I think obviously you can see there's a lot of real money involved. And I just like the fact that we can have some control over it. So.
And I'll say when we were down at the summit, so many employees that were just happy, healthy, productive employees. loving what they do because they're being very well taken care of.
Well, you get a $3,000 deductible and big copay. It's not really helping the average, employee making $35,000, $40,000 a year. Tell them we come out with $3,500 to even get coverage. It's not really a value to them. So we work at giving them an actual value.
Any Q&A out there? Somebody want to pass a mic?
So this, I'm particularly intrigued by your role, and I'm interested, how has the company shielded you, like from an employment law perspective, from having any transparency to decision makers with respect to compensation or termination of employment, any types of things like that, to make sure that you're sort of siloed off, given that you're given enough gravitas to make important decisions, but also but not have to go and go to senior management to get things cleared, where it may get back to who you were dealing with. So from an employment law perspective, how do you make your role work?
That has been asked of me before. So first off, I am the HIPAA privacy officer, which you all know that makes me basically their health lawyer. What I know you can't know, and I am completely separated from HR specifically for that reason. We don't want HR to have anything to do with any decision making capabilities based on someone's health or medical condition. And so I am housed in a completely different department. In fact, I'm not even in the same building with HR, and I don't share anything with them. And although I do see every single claim that comes through my desk, that does not get shared unless I have their express written consent.
And she's not telling people where to go. I mean, with the exception of the imaging or something like that, they're channeling through the resource partners, one of the bricks in the house, to do that. So she's not saying go see Dr. Price.
Yeah, I learned that lesson a long time ago when it came to the dentist, which is not as protected. And I don't like your dentist. Okay, well, so I don't say things like that anymore. I say, here's a way to look at the network. And we also have MAP, and their role is to help you find the best suited provider in the network for what it is that you need. And if someone gets really blunt with me and says, well, what do you think? I can say, well, I heard that there are several ladies here who use this pediatrician, and they find this pediatrician to be satisfactory to them. And that gets me off the hook of telling them you need to go here. You're welcome.
Any other questions?
Yeah, real quick. This is also for the folks at the inn. You all are 5 years, 6 years into this, and I like what Carl was saying about the crawl, walk, and now you're flying currently. So can you reflect back on maybe some of the early years, that member engagement piece that's so crucial? That's really the holy grail, I think, with what we're trying to do in this model. Can you speak to any of those early lessons that you learned in regard to that aspect of membership engagement, really inspiring that kind of different thinking among your people?
Well, we really tried to build a plan to give them the incentives we knew it was going to be more difficult to find a doctor or change doctors or do something like that. So part of the idea was the zero copays and the zero deductibles was to give them kind of a little financial incentive to go through some of those hiccups. We knew they were going to have somebody call and go, oh, they won't take your card, and who's the insurance company, and there's all this grief. So we kind of laid that out up front at the first meeting, and obviously reinforced that it was different, but it was to their benefit. We were going to give them zero money out of their pocket to kind of make the difference. That was part of it. And you continually have the people who are not going to participate. I'm going where I want to go. I'm not going to go to this hospital. I'm not going to go to that doctor. And so it's kind of a balance. The only weapon we really have, truthfully, is financial. I mean, you're going to pay more for that. Kind of like Carl said, we get this cash program. I want to go to the Mayo Clinic for this surgery. I don't care what it costs. That's what I'm going to go do. And then we can say, well, you say you don't care what it costs, but you're going to come up $2,500 out of pocket unless you let us work a cash price, and then maybe it's only $1,500. So even though they're in the high and mighty, I'm going to do what I want, $1,000 gets to them at some point. So it's a constant battle with that, but I think it really ends up being, we make the speech every year, show them some of these numbers. We're saving money. Your rates aren't going up. You need to participate. Like Carl said, we raised the rate a couple of years ago just so they can remember that there's financial incentive. And we talk about what their friends pay for coverage and what kind of coverage they get.
Those are great points. I think we need to wrap the session up, but
Okay.
we wanted to thank you, Liz, Christy, Glenn, and Carl. This is an amazing story and very inspiring for, I know, the entire crowd. So everybody, let's give them a big round of applause.